I'm Dr. FakhriRavari, and this is Skin and Soft Tissue Infections in Adults. Let's take a look at the significance of skin and soft tissue infections. In this retrospective cohort study of US administrative claim data, we can see that the incidence of skin and soft tissue infection is about 50 per 1,000 person years. And that is significantly higher than UTIs and pneumonia. And this high incidence leads to a huge economic impact. When we look at a period from the year 2000 to the year 2012, we can see that there was a threefold increase in direct healthcare costs driven by ambulatory care expenditure. And the total population-based antimicrobial prescription rates for SSTIs increased fourfold from the year 2000 to 2012. Here are some reliable resources for this topic. There is the 2012 IDSA guidelines for treatment of diabetic foot infections. There is the 2014 IDSA guidelines for management of skin and soft tissue infections. And in this topic, we will also cover beta-lactam allergies. So there is drug allergy, a 2022 practice parameter update, which is a helpful clinical tool. The first learning objective is identify risk factors for allergic cross-reactivity among penicillins, cephalosporins, carbapenems, and monobactams. When we look at adverse drug reactions in general, not just allergies, but all adverse drug reactions, they account for more than 3% of hospital admissions. Now, drug hypersensitivity reactions in particular compromise up to 20% of all adverse drug reactions, and they are reported in about 8% of general population. And that is all drugs, not just antibiotics or not just beta-lactam, but hypersensitivity reaction to all drugs. Now, the problem is up to 80% of allergies lack descriptions of the reaction. A modern way to look at adverse drug reactions is to think of them as on-target adverse drug reactions and off-target adverse drug reactions. On-target adverse drug reactions are reactions that are essentially based on the mechanism of the action of the drug. So these are things that we actually anticipate. An obvious example is antibiotics, right? So antibiotics are intended to kill microorganisms, but we don't necessarily want them to kill all microorganisms. Specifically, we don't want them to touch the microbiome. Pretty much most antibiotics are associated with C. diff infections, and that is an on-target adverse drug reactions. When it comes to off-target adverse drug reaction, it is useful to think of them non-immunologically mediated and immunologically mediated. Essentially, we need to know if the immune system is involved or immune system is not involved. Now, when the immune system is not involved, we can think of it whether the actual immune cells are involved or not, because some drugs can interact with the receptors on some of the cells, even though the immune system is not activated. An example is when fluoroquinolones interact with the cell receptors on the mast cells, resulting in urticaria. And this is not activating the immune system, but the end result is the mast cells causing urticaria. And that's something that we can see in fluoroquinolones. A non-immune cell receptor mediated example would be aminoglycosides causing nephrotoxicity, in particular acute tubular necrosis. Now, when the immune system is involved, it's good to think of it whether antibodies are mediating it or the T cells are mediating. And to go into more details on this, in general, we like to think of hypersensitivity reactions in 4 types. So type 1, which is the immediate hypersensitivity reaction, and by immediate we mean within an hour, you will have these reactions. It's mediated by IgE, so immunoglobulin E specifically, and this can manifest in serious things, so anaphylaxis, angioedema, flushing, pruritus, urticaria, and hives. Now, type 2 through type 4, these are the delayed hypersensitivity reaction. So by delayed, they're not going to occur within an hour. It will take some time, sometimes even days or weeks. And type 2 is the IgG-mediated cell destruction. And things like hemolytic anemia, neutropenia, petechia, and thrombocytopenia can manifest as a result of this. Type 3 is IgG-mediated immune complex deposition and complement activation. And things like drug fever, serum sickness, and small vessel vasculitis can manifest as a result of this. And last but not least, type 4 hypersensitivity reaction is T-cell mediated. And T-cell mediated reactions can be extremely severe. And because of that, we have actually broken type 4 into subtypes. So subtype 4A, B, C, and D. Type 4A specifically involves macrophages. And this is things like allergic contact dermatitis. And then for type 4B, which involves eosinophils, it can be things like DRESS, so that is drug reaction with eosinophilia and systemic symptoms. Type 4C is T-cell cytotoxicity, so these are extremely severe, so Stevens-Johnson syndrome, as well as toxic epidermal necrolysis. And there is type 4D, which involves neutrophils, and this could be acute generalized exanthematous pustulosis. So when we think of antibody-mediated hypersensitivity reaction, that includes type 1, type 2, and type 3. So these are all antibody mediated, different antibodies. So for example, type 1 is IgE. And when we think of T-cell mediated hypersensitivity reaction, this is specifically type 4. Now let's focus on beta-lactam allergy specifically. Now most patients labeled with a beta-lactam allergy are actually not allergic. And here are some reasons that they may have been falsely labeled as beta-lactam allergy. So one is that the original reaction might not have been an allergy, so there could be intolerance, for example, nausea, or diarrhea, or maybe the infection had caused a reaction. So for children, they could have had a viral exanthem, or a drug infection interaction. So if there is a skin reaction due to drug infection interaction, may have been interpreted as a drug allergy. Now, even if the original reaction were immunologic, it might not recur with re-challenge. And more importantly, IgE-mediated reactions to beta-lactams can wane over time. So about 80% of patients who are positive for a penicillin skin test, and 60% of those with a cephalosporin skin test positive are no longer sensitive over a period of 10 and 5 years respectively. Now, there could be serious unintended consequences of mislabeled allergies. So one is that mislabeling patients with a penicillin allergy can lead to the utilization of second-line antibiotics instead of preferred first-line antibiotics, which are costlier, broader spectrum, and in many instances associated with multiple adverse events. The other thing is that patients are expected to encounter more adverse effects and less optimal outcomes when using second-line antibiotics instead of first-line. And this in turn affects healthcare organizations as the length of stay increases, in addition to the cost of care of these patients. Now let's focus on penicillin allergy specifically, and by that I mean the class of penicillins, not just penicillin itself. Approximately about 10% of the US population reports a penicillin allergy, and about 5% of these patients who claim penicillin allergy will actually have a reaction to penicillin. And approximately 95% of patients with a reported penicillin allergy will have a negative penicillin skin test. So if you do the math, about 1% or less of US population actually have a true penicillin allergy. And even if the reaction was a true reaction, keep in mind that IgE antibodies wane over time, so that's important to keep in mind. When we look at the structure of penicillins, of course, there is the beta-lactam ring. For penicillin, there's also a second ring fused to the beta-lactam ring. But more importantly, there is a side chain. So there is a R1 side chain, and that depending on which penicillin, the R1 side chain will be different. And this will be, when metabolized, essentially you're going to have all these byproducts that are labeled as major determinant or minor determinant. And it is thought that the similarity between the R side chain as well as the degradation of the ring and the stability of the intermediate products determine the degree of cross-reactivity between beta-lactams. And since the overall structure of penicillins is identical and major and minor determinants from the rings play a potentially significant role, it is generally advised to avoid all penicillins in a severely penicillin allergic patient. And keep in mind that this is for severe penicillin allergy, not something as simple as a rash. Now, when it comes to cross-reactivity, we can think of similar side chains. So penicillin, for example, itself has a side chain that's similar to cefoxitin. So let's say if someone had a non-severe reaction to penicillin, like a rash, they're more likely to also have a similar reaction to cefoxitin. For amoxicillin and ampicillin, their side chain is similar to cephalexin. So if someone had a non-severe reaction to one of these, they're more likely to have similar reaction to cephalexin. Now, when we look at the big picture, if someone has penicillin allergy, the cross-reactivity between penicillins and cephalosporins is actually less than 2%. When it comes to penicillins and carbapenems, is less than 1%. And to date, actually, the rate of cross-reactivity between aztreonam and penicillins is essentially not reported. Now, if someone has cephalosporin allergy, the cross-reactivity between cephalosporins and carbapenems is less than 1%. Now, we have to keep in mind that in general, there is limited data with cross-reactivity when it comes to carbapenems and monobactams, because majority of penicillins, majority of beta-lactams that we use clinically are penicillins or cephalosporins. So we have much more data for cephalosporins and penicillins, less so for carbapenems and monobactams, which the only one in the US is aztreonam. Now, what to do when someone has penicillin allergy? Well, the first thing is that you want to evaluate and investigate to see if it's a true allergy or not. Because if it's not a true allergy, if it's something like intolerance, such as nausea or vomiting, it's safe to use beta-lactams. It's not allergy. Now, when it is a delayed reaction, you want to be very careful because it could potentially be T-cell mediated, and that's very severe. So if it's non-severe, something like itching, even if it's delayed, it is in general safe to administer cephalosporins, carbapenems, and aztreonam, and you don't really have to worry about the side chain. But if it is a severe infection, such as Stevens-Johnson syndrome, and these are T-cell mediated, you really want to avoid cephalosporins and carbapenems, regardless of what the side chain looks like. And it is safe to use aztreonam. So aztreonam will be your only beta-lactam that you can use. Of course, it's safe to use non-beta-lactams. Now, when it comes to immediate reactions, these are within an hour, that could be potentially IgE mediated. For non-severe, it is safe to administer aztreonam or carbapenems. If you are to use a cephalosporin because there's potential for cross-reactivity, you really want to rely on the side chain. So you want to use one that doesn't have a similar side chain. If it is a severe reaction like anaphylaxis or angioedema, you really want to avoid cephalosporins and carbapenems that have similar side chain, because it could potentially lead to anaphylaxis. It is safe to use aztreonam, and if you are to use the side chain to decide if it's a cephalosporin that's safe, it has to be in a monitored setting, because there's the risk of anaphylaxis. So if if you're sending the patient home, it's best not to rely on the side chain and avoid it. But if it's in a monitored setting, it's you can use the side chain. Now, when it comes to cephalosporin allergy, about 1 to 3% of the population report cephalosporin allergy, so even more rare to have cephalosporin allergy, so less than 1% have true IgE reaction. Now, with cephalosporin, there are actually two side chains. So there is the R1 side chain. They actually have a R2 side chain. And the second ring is slightly different than the penicillin. The beta-lactam ring is, of course, identical. Now, something that stands out is that cefazolin actually has a unique side chain. So it has very low cross-reactivity with penicillins. No other beta-lactam has the same cephalosporin side chain. So that's good. So when it comes to deciding similar side chains, we really rely on the R1. Although the R2 side chain may have a role in immunogenicity, it is to a lesser extent. So we'll focus on similarities of the R1 side chain. So I have listed some of, this is not an extensive list, so some of the more commonly used cephalosporins, especially the ones in bold. So as I mentioned, cefazolin does not have similar side chain with anything else. Cephalexin, of course, with ampicillin and amoxicillin, as well as penicillin. Cefoxitin with penicillin, cefpodoxime with cefepime and ceftriaxone. Ceftriaxone, cefepime, and cefpodoxime pretty much share the side chain. So those are, best to avoid when one of them is causing a severe reaction. Ceftolozane has similar side chain with cefpodoxime, ceftriaxone, cefotaxime, and cefepime as well. And lastly, with carbapenem allergy, again, even more rare and really limited data with carbapenem allergy. It's not studied as well. The risk of cross-reactivity between penicillins and carbapenems is less than 1%. Now, because carbapenems are unique in that when we need to use carbapenems, we're dealing with some severe infections that we really need carbapenems. And so, it will be tough if you really need carbapenem, and the reason for not being able to use it is a drug allergy rather than resistance. So based on limited data available, an alternative carbapenem agent may be cautiously used in patients with reported carbapenem allergy if no other option for treatments are available. What that means is if someone has imipenem allergy and you really need a carbapenem, you can cautiously use meropenem under monitoring. We identified risk factors for allergic cross-reactivity among penicillins, cephalosporins, carbapenems, and monobactams. Now, let's distinguish between common types of superficial and necrotizing soft tissue infections, including causative pathogens. Here are some terminology of skin lesions that are helpful when discussing skin and soft tissue infections. So a macule, and you can see a picture of it here, is a flat circumscribed area that is a change in the color of the skin. Now, a papule is a small raised solid pimple or swelling, often forming part of a rash on the skin and typically inflamed but not producing pus. A vesicle is a small fluid-filled sac, and a pustule is a small blister or pimple on the skin containing pus. So you can visibly see the pus here. And bulla, which some would call it a blister, is a bubble-like cavity filled with air or fluid. And of course, crust is the dried serum, blood, or purulent exudate, which is typically the final phase of skin lesions. It's important to consider the anatomy of skin and soft tissue structure when discussing skin and soft tissue infection. So you can essentially think of the layers here. So at the very top, we have skin. Under the skin is the subcutaneous tissue, and then under that there is muscle. Now within skin, we can think of epidermis and dermis. Epi means above, so epidermis is above dermis. And then in the subcutaneous tissue, we have superficial fascia or fascia. And then under it, we have subcutaneous fat, nerves, and arteries and veins. and followed with deep fascia, and of course muscle underneath. Now, depending on what layer, we will talk about specific infections based on how deep we go into the skin structure. Now, impetigo or impetigo, characterized by erythematous papules, which then develop into vesicles and pustules, will eventually form a honey-colored crust, and this is essentially in the epidermis layer. Ectyma or ecthyma essentially is similar to impetigo, but it extends into the dermis skin layer, so it's still in the skin, but it's a bit deeper. Furuncle or a boil is an infection of the hair follicle that extends through the dermis and into the subcutaneous tissue. Carbuncle is infection involving several adjacent follicles that are deeper than furuncle, which typically drain pus from several orifices. An abscess is a collection of pus within the dermis and deeper layers of the skin. Cellulitis is an acute spreading inflammation of the epidermis, dermis, and possibly the superficial fascia. It's characterized by erythema and edema of the skin that is not elevated and has poorly defined margins. Erysipelas is similar cellulitis but with a raised border and clearly demarcated margin. These infections are considered superficial in the sense that they are not necrotizing. When it comes to necrotizing soft tissue infection, essentially we get deep into the skin tissue. Cellulitis is kind of unique because it can be superficial, but it can also cross into deeper tissue. So there, a small portion of cellulitis can be necrotizing. So it will be the necrosis of dermal and subcutaneous tissue. However, once we go into the fascia, we essentially label it as necrotizing fasciitis. And when the muscle is involved underneath, it's essentially a myonecrosis. Now, there are different parts of the body that can have different types of necrotizing soft tissue infections. So you can see on this picture, and there are different ways to classify this. So one method is to have type 1, 2, 3, and 4, and there are some disagreements over this typing. But essentially, as of 2023, a proposed classification is that type 1 is essentially polymicrobial infection, when it comes to necrotizing. Type 2 necrotizing infections are monomicrobial, so typically group A, strep or Staphylococcus aureus. Type 3 is reserved specifically for Vibrio vulnificus or Aeromonas hydrophila, and type 4 for fungal infections. All necrotizing infections are considered a medical emergency, so they need to essentially be evaluated by surgeons urgently. And one thing that's important to understand about pathophysiology of necrotizing soft tissue infections is the presence of toxins. So the two or three common organisms that cause necrotizing, group A, Streptococcus. So this is Streptococcus pyogenes, is known for producing exotoxins. And, when these toxins essentially enter the tissue, they can cause severe necrosis. Staphylococcus aureus, some strains of Staphylococcus aureus can also exhibit exotoxins. As well as some Clostridia species. So Clostridium perfringens, for example, produces exotoxins. And what's to understand is that exotoxins have a role in necrotizing skin infections. And that's something that we'll talk about when we talk about selecting appropriate treatment. So we will need something with antitoxin effect. Now, because Staphylococcus aureus is often found on the skin, so it has a huge role in skin and soft tissue infections. So it's important to consider, in particular, methicillin-resistant Staph aureus or MRSA. Now, the good news is that the incidence of MRSA infections, in general, all infections, not just skin and soft tissue infections, in the hospital are actually declining year after year. So this was the 2019 CDC data that showed up to 2017 that, it's dropping. However, it's important to notice that when you compare to other infections, that MRSA is actually pretty common. So, estimated cases in hospitals patients in 2017 was over 300,000 cases, whereas C. diff was about 223,000. Erysipelas 197. So you compare to other, bad organisms, MRSA is pretty much, more common. And when you consider estimated death, although more people have died from C. diff in 2017, still, over 10,000 people have died as a result of MRSA infections. And that's all infections in general, not necessarily skin and soft tissue infections, just to emphasize the importance of MRSA when it comes to infections. Now, with skin and soft tissue infections in particular, we can kind of consider severity on a spectrum. So, impetigo and eczema, very superficial. So, impetigo is in the epidermis and thymus into the dermis, right? So these are pretty mild in general, and they may be less severe or even similar to purulent SSTI. So purulent meaning that it doesn't matter what type of SSTI, it's essentially producing pus. And most severe would be necrotizing SSTIs that could lead to essentially toxic shock syndrome and mortality. Now, impetigo is broken into bullous and non-bullous impetigo. Essentially, most common cause of bullous impetigo is toxin-producing Staphylococcus aureus, and most of these are actually MSSA, so we're not really concerned about MRSA specifically. Non-bullous could be due to beta-hemolytic streptococci. So that's, essentially group A strep, Streptococcus pyogenes, or Staph aureus, or both. And that's still MSSA. So it's not necessary to cover MRSA for these superficial infections. When it comes to, I should mention this is the same for eczema as well. For purulent SSTIs, and some examples of purulent includes furuncle, carbuncle, and abscess. This is primarily Staphylococcus aureus, and that could be MRSA, so MSSA or MRSA. With cellulitis or Erysipelas, it is mostly beta-hemolytic strep, and rarely it can be group B or Staphylococcus aureus. And the most severe necrotizing fasciitis, that's typically due to beta-hemolytic strep, and that's commonly due to MRSA, Aeromonas, or Vibrio vulnificus. And when there is, gas gangrene, that's typically due to Clostridia species. So Clostridium perfringens is, one of the common causes of gas gangrene. Now, when we look at all skin and soft tissue infections in general, most typically, collectively, most typical implications are due to Staph aureus and beta-hemolytic strep. So you will see that the treatment is targeting these two organisms for the most part. Now, 80% of culture positive infections are from these two. And when it comes to Staph aureus, community acquired MRSA, is a big portion of it. And sadly, when you look at some of the data, you will see that when you compare inappropriate antimicrobials to appropriate antimicrobials, when it comes to Staphylococcus aureus, a good portion of treatments have been inappropriate, meaning no coverage, either due to resistance or due to, inappropriate selection of antimicrobials. And that was, the ones with this are statistically significant. So less frequently implicated are, gram-negative organisms. So in general, we're not really worried about gram-negatives, anaerobes and yeast. Now, with clinical presentation of skin and soft tissue infections, Essentially the hallmarks are erythema, swelling, warmth, induration, pain or tenderness at the site of infection, and for some of them that are purulent, draining, possible be coming from the wound. And they may be accompanied by signs and symptoms of a systemic illness. For example, there may be, depending on the severity, there may be fever and chills, diaphoresis, malaise, or elements of SIRS criteria. And we will use these to actually, when we select treatment, we will label some of these as mild, moderate, or severe, which I will discuss when I go over treatment. We identified risk factors for allergic cross-reactivity among penicillins, cephalosporins, carbapenems, and monobactams. We distinguish between common types of superficial and necrotizing soft tissue infections, including causative pathogens. Given a patient with a superficial skin and soft tissue infection, let's recommend IDSA guideline-concordant treatment. Staphylococcus aureus and group A streptococci constitute the large majority of skin and soft tissue infections. This is a slide from the CDC, which essentially ranks different resistant organisms based on threat level. So for erythromycin resistant group A strep, this is a level concerning. So they have 3 levels: concerning, serious, and urgent, and this one is concerning. In particular, resistance to erythromycin has been increasing year after year, and erythromycin is the surrogate for the entire class of macrolides. So essentially we can consider this resistant to the macrolide antibiotics. And in addition, we're also seeing increasing rates of resistance to clindamycin. Let's take a look at the spectrum of activity of common antibiotics used for skin and soft tissue infection. Of course, here we have viral type strep pneumo, drug resistant strep pneumo, beta hemolytic strep, MSSA, MRSA, and some gram negatives. Now, in particular, we are going to focus on beta hemolytic strep and MSSA and MRSA. So you can see that penicillin has excellent activity against beta hemolytic strep, but no activity against MSSA or MRSA. The same for amoxicillin, no activity against MSSA or MRSA. And because amoxicillin standard dose has excellent activity against beta hemolytic strep, there's really no role for a high dose amoxicillin that normally will work well for strep pneumo. For beta hemolytic strep, it's unnecessary to use high dose amoxicillin. Now, when we want both beta hemolytic strep coverage and MSSA, because MSSA makes penicillinases, there is a need for clavulanate. So amoxicillin clavulanate, excellent activity for both beta hemolytic strep as well as MSSA, but no activity against MRSA. Dicloxacillin, which is our anti-staphylococcal penicillin, has excellent activity against MSSA. In fact, one of the drugs of choice for MSSA. And in general, it has good coverage for beta hemolytic strep. But there are some strains of beta hemolytic that may be resistant to dicloxacillin. So if we have other options for beta hemolytic strep, it's best to use those. But still, it does have high activity against them. Cephalexin, your first generation cephalosporin, essentially excellent activity against beta hemolytic and MSSA, and that's true with pretty much most of first generation, second generation, and third generation. The only exception with the second generation is the cephamycins are not included. Of course, we don't have oral options for cephamycins, but the rest of second generations have excellent activity against beta hemolytic strep. Bactrim has excellent activity against beta hemolytic strep and MSSA, and also against community-acquired MRSA. Now, there is historically been a myth about trimsulfan not being active against beta hemolytic strep, and in fact, the 2014 IDSA guidelines typically do not recommend Bactrim anytime that you are covering beta hemolytic strep. However, in recent time, that myth has been debunked, and anytime that we have concern for beta hemolytic strep, trimsulfa is an excellent choice. With clindamycin, as I mentioned, there is increasing rate of resistance in beta hemolytic strep. The same in community-acquired MRSA, there is increasing rate of resistance to clindamycin. It does, however, maintain good activity against MSSA. Ciprofloxacin in general has poor gram-positive coverage. It can cover MSSA, but no coverage for MRSA or beta hemolytic strep. The levofloxacin and moxifloxacin, those are the two that have excellent activity against beta hemolytic strep, as well as MSSA. And levofloxacin doesn't cover MRSA, but moxifloxacin can cover some community-acquired MRSA. But the rate of resistance can also be might be increasing in moxifloxacin. Azithromycin and the rest of macrolides, so erythromycin was the surrogate for this class. As I mentioned, rate of resistance in beta hemolytic strep is increasing, and that's very concerning. Still active against MSSA, no activity against MRSA. And lastly, the entire class of tetracycline, so doxycycline, most commonly used as oral agent, has poor activity against beta hemolytic strep. So anytime you need beta hemolytic strep coverage, you should not be using doxycycline. It is an excellent choice if you need MRSA or MSSA coverage. So it's oral and excellent coverage against community-acquired MRSA. Here are the IDSA recommendations for the management of impetigo and eczema. As we have discussed previously, impetigo is essentially the infection of the epidermis. Eczema can also go into the dermis layer. So eczema is deeper level. So that's something to keep in mind when we're deciding to use topical or oral agents. So in general, we know that the most causative pathogens are MSSA, most common, and beta hemolytic strep. So with impetigo, because it's only in the because it can be in the epidermis only, we can use topical agents. So these are some ointments and creams that patients can apply to the area, and that's best because it goes to the site of infection and it doesn't cause collateral damage, for example, affecting the gut microbiome. Now, with both impetigo and eczema, because it goes to dermis layer, oral antibiotics are recommended. And the way you choose between topical and oral for impetigo, essentially the number of lesions affected, and also if there are multiple people in the household might be at risk of getting the infection, so for infection control or transmission control. But anyway, for oral treatment options, when targeting MSSA and beta hemolytic strep, which are the most common causes, oral agents, cephalexin, amoxicillin, clavulanate are the best coverage. So cephalexin most commonly. The problem with cephalexin is that patients have to take it 4 times a day, whereas amoxiclav you can do it twice a day, so it's nicer. Other options include dicloxacillin and clindamycin, so they may not be the best for beta hemolytic strep, but they are available options in case the other ones are not available. And of course, Bactrim will also cover MSSA and beta hemolytic strep. In general, Bactrim is reserved when you need MRSA coverage. Clindamycin is not the best thing for MRSA coverage. So Bactrim and doxycycline have much better MRSA coverage. Now, if you do use doxycycline, keep in mind that it does not cover beta hemolytic strep. So if you're using doxycycline for MRSA coverage, you need a second agent to cover beta hemolytic strep. And there is no need for IV treatment. So impetigo, relatively, the least severe type of skin and soft tissue infection compared to other types of skin and soft tissue infection. Now, gram stain and culture of the pus are recommended, if available, but it's, treatment without these is also reasonable. So, if you don't have culture results, you can totally do these creams or these treatments for 7 days and you'll be done with treatment. Now, these are the regimens that I had mentioned, so keep note of the frequency of doses, because some of these that are 4 times a day, they are less likely to have adherence in patients. Now, slightly more severe is purulent skin and soft tissue infections. So these are things like abscess, carbuncle, furuncles, and essentially for treatment of these, which, because pus is driving these, so these are purulent, the large majority are Staphylococcus aureus, okay, either MSSA or MRSA. And it is possible to have beta hemolytic strep, right? So Streptococcus pyogenes could be pus generating, but in general they are rare. So the treatments are essentially targeting Staphylococcus aureus. Now, we do need to assess the severity of purulent infections and break it into mild, moderate, and severe, and that's driven by presence or absence of SIRS criteria. So if no systemic signs of infection, that's essentially mild, and all you need to do is incision and drainage. So essentially it's a source control strategy. So once you remove the pus, the patients will recover, so no need for antibiotics. Now, if there are systemic signs of infections, and the patient should, of course, be hemodynamically stable, in addition to incision and drainage, the patient will receive oral antibiotics. Okay, so oral antibiotics that's primarily targeted at MRSA. So trimsulfa or doxycycline, and for some reason, if these are not available, clindamycin. Clindamycin last choice, not only because of increasing rate of resistance, but also collateral damage from clindamycin is much more severe. So C. diff in particular is an issue. Now, if there are culture results available, of course, we want to de-escalate once the culture results come back. Of course, these are pretty narrow in general, so there's not much we can de-escalate. But for example, when we go to severe, and that's essentially if somebody previously had incision and drainage and PO antibiotics and they failed treatment, they essentially get labeled as severe infection and they would require IV antibiotics in addition of incision and drainage. Or if somebody had multiple systemic signs or plus acute hypotension, organ dysfunction, or if somebody is just immunocompromised. So if it doesn't have any of these, purely if a patient is just immunocompromised, we will consider that the severe infection, and they will have to receive IV antibiotics. And again, antibiotics are targeting MRSA. So our drugs of choice are vancomycin for the largest, for the most part, but also daptomycin, linezolid, ceftaroline. And there are some, long-acting anti-MRSA agents that we have that even a single dose is good enough. These are dalbavancin and oritavancin. Their half-life is somewhere between 200-300 hours, so they're pretty long. So a single dose will actually last for a week or so. So IDSA guideline recommendations do say to gram stain and culture of pus, are recommended, but again, depends on the severity, so you may not necessarily need those. Incision and drainage is the cornerstone of purulent skin and soft tissue infections, and we discussed how to choose anti-Staphylococcus aureus agents. For clindamycin, one thing that's become significant, especially when we have to de-escalate based on culture and susceptibility results, is the concept of inducible clindamycin resistance and the D-test. So in general, clindamycin resistance is very common in healthcare associated MRSA, and that's why we don't use it anytime we suspect MRSA in hospital associated infections. But it does have activity against community acquired MRSA, but as I mentioned, the rate of resistance is increasing. Now, the concept of macrolide inducible resistance to clindamycin is very interesting. So there is the MLSB phenotype, and that essentially stands for macrolides lyncosamides, which essentially clindamycin is the only drug in this class. So we usually just say clindamycin, but lyncosamides and group B streptogramins, quinopristine, which we don't really use clinically, so you will not really see this in this course. But this phenotype essentially is a cross-resistance between these three classes of drugs. And what that means is that, so the resistance is the result of an enzyme. So it's a methylase enzyme that's encoded by a plasmid-borne gene called ERM or ERM. And so this gene needs to be active to produce this enzyme, which will break down all three of these classes, right? So, this gene could just be always on. So we call that constitutive expression of the gene. So if it's always on, when you get your susceptibility results back, you will see that, Staphylococcus aureus is resistant to erythromycin and clindamycin, and of course, quinopristine, which we don't really test since we don't use it clinically due to, a lot of adverse effects to that. Now, the other thing that can happen is inducible. So maybe this gene is not always on in Staphylococcus aureus, but maybe it will be induced when you use one of these agents, okay? And most likely, if it's inducible, it can easily be induced by macrolides. It may take longer for clindamycin to induce this. And essentially, all these have the same binding site, and that's why there is a cross resistance and the same mechanism. So the problem is, if it's inducible and you get your susceptibility results back, it may show resistant to macrolides, but susceptible to clindamycin. And that's a problem because then you might say, okay, it's resistant to macrolides, so we don't use macrolides, but we will use clindamycin. And then while the patient is receiving clindamycin while on treatment, resistance might emerge and lead to treatment failure. So the way to catch inducible resistance is to do the D-test. So the D-test is essentially that when you have a plate, so here's a cartoon over here. So you have your agar plate, where your Staphylococcus aureus is growing, and you drop two discs. One disc has erythromycin, the other one has clindamycin, and then once you drop the disc, antibodies will diffuse in a radius around the disc. And if it's killing Staphylococcus aureus, that means nothing will grow around the disc. So you have a zone of inhibition. So here's erythromycin and here's clindamycin, and that essentially means that it's susceptible to both agents. Now, if it grows through the disc, that means, it didn't care that there was antibiotics here, it was resistant to it, so it actually grew through, it did nothing. Sometimes you may get, so I will use the example over here. So the panel C, you can see that there is a large zone of inhibition around clindamycin, but it is, it actually has grown close to the disc of erythromycin. So panel C over here shows resistant to erythromycin, but susceptible to clindamycin. Now that's how it normally should be, right? The D test is that if the same test shows you a D-shaped instead of a complete circle, essentially means that because, obviously this is resistant to erythromycin, and erythromycin is diffusing through this plate. So the idea is that as you get, the area that's close to erythromycin, because there is some erythromycin in this area over here, it has essentially induced resistance to clindamycin. So instead of having a complete circular shape, Staphylococcus aureus was actually resistant to the area over here. So essentially means the Staph aureus that was over here got, induced, and it's actually resistant to clindamycin. Whereas on the other side, you don't really have erythromycin over here, so it did not induce resistant to clindamycin. So you have a zone of inhibition. So what that means is that you have a D shape. So this is so panel D is D test positive and panel C is D test negative, which means that if you have D test negative, it's okay to use clindamycin clinically. When you have D test positive, it's recommended not to use clindamycin because it's possible that once the patient starts receiving clindamycin, halfway through the treatment, there may be enough induction to cause resistance to clindamycin, leading to treatment failure. Now, before we move on to non-purulent skin and soft tissue infection, I want to emphasize the role of incision and drainage, or incision and debridement. So essentially, in purulent, incision and drainage or debridement is the mainstay of therapy. Whereas for non-purulent, because there is no pus, for the most part, it's really antibiotic therapy, the cornerstone of treatment. So here, slightly more severe is cellulitis, and we know that cellulitis goes deeper into the skin, so it can actually be it can have dermis layers, as well as it can go deeper, a little deeper into subcutaneous layer. So again, with non-purulent skin and soft tissue infection, the most common cause is beta-hemolytic strep, and it can also have MSSA or MRSA as a contributing factor. Just like purulent SSTI, we break non-purulent SSTI into mild, moderate, and severe using the same criteria. So mild is no systemic signs of infection, moderate is systemic and hemodynamically stable, and severe essentially means failed PO antibiotics or multiple systemic signs plus organ dysfunction or immunocompromise, or if signs of deeper infection. So one thing with non-purulent SSTI, we're getting one step closer to the most severe skin and soft tissue infection, which is necrotizing. So if you suspect signs of necrotizing skin and soft tissue infection, that will be considered severe. So for mild, so note that incision and drainage is not driving treatment, so it's antibiotics. So for mild, we do use oral antibiotics, and this is geared towards beta-hemolytic strep. So penicillin is okay. The problem with penicillin is 4 times a day. So even though we're not covering Staphylococcus aureus, penicillin is okay. So people usually don't use it just because it's 4 times a day. Cephalexin is also 4 times a day, so it has the same problem, but it also covers MSSA. Trimsulfa, which is not in the guideline because they thought that it doesn't cover beta-hemolytic strep, but we have learned that it does. Amoxiclav is also not included in the guideline for some reason, but we know that it has excellent activity against beta-hemolytic and MSSA, and it's twice a day dosing, so it's very convenient. And then for moderate, you want to go to IV antibiotics, and also with mild, so it's more, these patients can be treated in the outpatient setting. With moderate, IV antibiotics. So these patients typically get hospitalized not only because IV antibiotics, but this is getting one step closer to severe, which can lead to necrotizing skin and soft tissue infection. So this is why although these patients are hemodynamically stable, we use IV antibiotics because we want to manage this as soon as possible to minimize the risk of necrotizing skin and soft tissue infections. So for these patients, of course, cultures of blood and cultures of swabs of of the infection site is recommended. And when targeting beta hemolytic strep, penicillin is still recommended, except this time it's IV. Now, when covering both beta hemolytic strep and MSSA, cefazolin is the drug of choice. So first generation. Some people might use ceftriaxone once a day, but it's more likely to cause collateral damage, ceftriaxone. And of course, clindamycin is there too. And then for severe, this is where, you want to really act quickly and, mobilize multiple teams, including surgical evaluation is really important to make sure that it's not getting to the necrotic point. And at this point, broad spectrum antibiotics are actually recommended. So I know that we're trying to cover beta hemolytic strep and MSSA, but we're actually going to cover gram negatives because this is getting serious. So, we don't want people to die. So vancomycin to take care of, MSSA, MRSA, you do want to cover MRSA for these severe infections. So vancomycin plus piperacillin tazobactam is what's routinely used. And also, these have anaerobic coverage too. So piperacillin tazobactam, in case there is necrotic tissue with anaerobes growing, they have pip-tazo. Now, the guideline has listed carbapenems because they also cover, gram negatives, including multi-drug resistant gram negatives and anaerobes. So in general, we want to avoid this if we can because of the collateral damage from carbapenems. And of course, when the results of culture and susceptibility are back, we want to de-escalate as quickly as possible. Here are the recommendations from IDSA guidelines, so in accordance with what I had on the previous slide. So please pause this video and review these recommendations. One thing I want to emphasize, duration of treatment for cellulitis is 5 days. So 5 days, unless the patient is not improving, but if everything is going according to the plan, 5 days is sufficient. And lastly, the guidelines say for systemic corticosteroids, so for example, prednisone 40 mg daily for 7 days could be considered in non-diabetic adult patients, and that is essentially to control the inflammation in the site of infection. We identified risk factors for allergic cross-reactivity among beta-lactams. We distinguish between common types of superficial and necrotizing soft tissue infections. And given a patient with a superficial skin and soft tissue infection, we recommended IDSA guideline-concordant treatment. Now, given a patient with a necrotizing soft tissue infection, let's recommend IDSA guideline-concordant treatment. To display the severity of necrotizing soft tissue infection, let's take a look at a few pictures. So there are 3 patients here. So panel A, C, and E are 3 different patients, and then they're showing you before and after surgical debridement. So although, when you look at panel A, it may not seem like a serious infection, but this is something that, unfolds very quickly. And what's going on underneath, so the necrosis is really happening underneath. So you can't really, see immediately how severe it is until surgical evaluation. And of course, the end result is that once they have removed, necrotic tissue, and manage the source of infection, this is the final result, which is extremely severe. These infections start with the usual symptoms of swelling, erythema, and pain, and what we look for is signs of systemic nature. So tachycardia, so essentially the SIRS, as well as markers of inflammation, so CRP. Elevated CK level can quickly indicate that there is a significant muscle damage, so myonecrosis is going on, and there is a risk score that we will not discuss here. But essentially, when necrotic or necrotizing soft tissue infection is suspected, the team essentially uses radiographic imaging to identify if they can see gas. And on imaging they can actually see if there is gas present or not, And that's one thing that's done very early, because if there is gas, seen, that's something that essentially leads us to our Clostridial species. Whereas if there is no gas, that's more likely to be Streptococci and other organisms. So if there is no gas seen on imaging, of course, we do need, surgical evaluation, incision, debridement, and of course, specimen is always collected for culture and susceptibility. And so for gram-negative rods, if there are gram-negative rods suspected, essentially Aeromonas. So these are some of the water-loving organisms. So Aeromonas is found in fresh water. So, let's say somebody is enjoying nature outside, some fresh waters, and there was a skin damage, and Aeromonas found its way in. So those are some things that the team will ask if the patient has had exposure to fresh water, whereas Vibrio species are found in salt water. So if somebody's been, swimming in the ocean, where salt water, so Vibrio really can tolerate high concentration of salt. And also Vibrio vulnificus is something that you may hear on the news if somebody had severe infection, by simply eating raw oyster. So, that's essentially oysters are coming from salt water, and, they could potentially have Vibrio vulnificus causing severe necrotizing infection. For gram-positive, of course, we've talked about strep pyogenes. So that would be, one of the more common ones, but also Staphylococcus aureus. And these can produce toxins, so toxin-generating strep pyogenes, as well as Staph aureus. And then if you do see gas, so gram-positive rods, that's essentially Clostridial species. So there are different species of Clostridium, more commonly Clostridium perfringens. And this can be extremely severe, that goes to the level of myonecrosis. So it goes past the soft tissue and find its way into breaking down the muscle underneath the soft tissue. So, and that's why people look for gas early on to identify this. And of course, if you don't suspect any of this, then you go the usual route of non-purulent skin and soft tissue infections, which include cellulitis, which we have discussed previously. So here are the IDSA guideline recommendations. So they do recommend prompt surgical consultation, and for patients with aggressive infections associated with signs and symptoms of toxicity, suspicion of necrotizing fasciitis and gas gangrene. Empiric treatment should be very broad. So these are, severe infections. So we don't mess around. So you'd want to cover your MRSA. So either vancomycin or linezolid. Linezolid gives you an extra advantage because it has antitoxin effect. So if you're, I personally like linezolid, but the general practice is that, majority of hospitals are using vancomycin. And then plus you need so this is broad spectrum. Then you need a second agent to go with your MRSA agent. So piperacillin tazobactam is the most commonly used, because you also want some anaerobic coverage because of the necrotic nature of this infection. And for that reason, carbapenems are listed here. If somebody could not get these for whatever reason, an alternative is, in addition to vancomycin or linezolid, you do combination of ceftriaxone and metronidazole. So I mentioned the anaerobic, so ceftriaxone doesn't have anaerobic coverage, so people would add metronidazole to ceftriaxone in case that's what they were using. And a good example would be, if someone cannot tolerate piptazo, or if there is a shortage of piptazo and you wanted to avoid carbapenems, and go to ceftriaxone and metronidazole. And every now and then there's also metronidazole shortage. And it's not uncommon for these infections to be polymicrobials, which explains why we need broad spectrum regimens. Now, penicillin plus clindamycin is the treatment of choice for documented group A streptococcal necrotizing fasciitis. So group A streps, So that's Streptococcus pyogenes, which 100% of them are susceptible to penicillin. So penicillin, drug of choice, proven efficacy and no resistance, essentially zero resistance to penicillin. And then you might ask, why do we need to add clindamycin here, where group A might actually be some of them resistant to clindamycin? And that's because clindamycin has the antitoxin effect, and we're dealing with a necrotizing fasciitis, so clindamycin will handle the toxins and penicillin will handle the organism making the toxin, because penicillin alone will kill the organism, but the toxins are circulating around, so you want to neutralize those with clindamycin. And here are recommendations for clostridial gas gangrene or myonecrosis. And the difference between necrotizing fasciitis and gas gangrene, essentially necrotizing fasciitis driven by streptococci and gas gangrene by clostridial species, so Clostridium perfringens. So the recommendation is urgent surgical exploration when gas gangrene is suspected. We do want broad spectrum empiric treatment, so we don't mess around. So vancomycin plus something that has anaerobic coverage, so piptazo or ampicillin sulbactam or carbapenem are recommended. And definitive treatment, once it's confirmed that it's clostridial myonecrosis, is penicillin plus clindamycin. And here's a slide from the guidelines. So this is a figure from the guideline for non-purulent, which includes necrotizing fasciitis, right? So necrotizing fasciitis specifically will be under severe. So empirically, you want broad spectrum coverage. But then I want to bring your attention to the pathogen-directed part. So once your culture and susceptibility results are back, you can de-escalate from broad spectrum to pathogen-directed. So if it's Streptococcus pyogenes, we mentioned penicillin and clindamycin. If it's Clostridial, penicillin and clindamycin. If it's Vibrio, doxycycline plus ceftazidime. So here we're not worried about toxin production. Aeromonas is doxycycline plus ciprofloxacin. And of course, if it's polymicrobial, you just there's not much you can do, so you'll just maintain your empiric treatment, broad spectrum treatment of vancomycin plus piptazo. If you cannot pinpoint what's causing it, because these are severe infections, so patients can die from necrotizing soft tissue infections. So this concludes this presentation.